So hello and welcome to iTenif Healthcare Solutions webinar. Today we're going to be presenting Quality Care Program Reporting. So many choices, so little time. My name is Chelsea Grover and I'm the Marketing Communications Coordinator for iTenif. I'd like to take a moment to explain the process for today's presentation. First, I'd like to mention that this webinar will be recorded. Next, for those of you who aren't familiar with iTenif, I wanted to share a bit of who we are with you. We've been in business as iTenif since 2003, but we were next-gen users since 1997, EPM version 2.3. We specialize specifically in next-gen healthcare. Our development team knows how to get data into, out of, around, and through next-gen to customize it and tailor it to meet our clients' unique needs. Our purpose in life is to create delighted clients by helping them get the absolute most out of their next-gen software investment. It is our passion to provide solutions for our healthcare provider partners, which in turn help them to improve patient care, enhance the patient experience, and maintain a financially healthy practice. We really do everything next-gen, from consulting to hosting, customization to support, and we have two next-gen add-on productivity solutions, CheckGuard and Refund Manager. We're here to help. Next, I wanted to bring your attention to our upcoming three-part webinar series, Improving Next-Gen Efficiencies with iTenif Products and Services. In it, we're going to share some of the tips and tricks that we use to make our next-gen run more efficiently, present some packages that we offer to do it for you, and ways that you can help optimize your workflow and keep your systems healthy. It starts on May 18th with iCare Server Health. Keep your eyes out for a webinar invitation from us in May. Okay, so going back to quality care reporting. At the end of the presentation, we're going to open the floor up to questions from you. We'll answer all the questions at the end, but you may type them in the questions area of the webinar control panel whenever they occur to you. For your reference, we'll also be emailing links to the recordings of the PDF and presentation later this week, as we do with every webinar. Finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you experience audio issues, please use the chat box to let us know so we can resolve them. So without further delay, I'd like to introduce our presenters for today. Lindsay Lanning, Kathy Thompson, and Cindy Kincaid will be available to help with questions at the end. Lindsay Lanning originally joined us from the Ohio State University intern program, where she was getting her degree in Health Information Management Systems. After graduation, Lindsay joined our team as the Healthcare Informatics Coordinator, where she spends her time immersing herself in the ever-changing healthcare IT environment and educating the rest of the company on new issues and trends in the industry. Kathy Thompson has been with iTenif for 10 years. Prior to joining iTenif, she was a medical assistant at a neurosurgical practice. This is where she got her first taste of NextGen and has been hooked on it ever since. Currently, she is managing consultant at iTenif, where she specializes in NextGen EHR and incentive programs. And Cindy Kincaid, who's going to be available for questions at the end, is Vice President of Consulting Services at iTenif and a Certified Practice Management Executive. With over 25 years in the IT healthcare industry and 9 with iTenif, her experience runs wide and deep. This makes it possible for her to provide the insights needed to help healthcare organizations experience great success no matter what the challenge is. Okay, so Lindsay, I'm going to go ahead and pass the webinar off to you. Feel free to get started when you're ready.
Great, thank you, Chelsea. Hi, everyone, and thank you for joining us today for our webinar, Quality Care Program Reporting, So Many Choices, So Little Time. With the vast amount of regulatory requirements imposed on the healthcare industry today, we want to take the time to dissect the different quality reporting options and differentiate between them. This webinar will offer a high-level view of the most prevalent reporting programs available and go through what they are, what their requirements are, and how they all relate. Our hope is to leave you with a basic understanding of what each quality reporting program is and be able to differentiate between them. So in today's webinar specifically, we will look at an introduction to quality reporting. What is it and how does it affect you? The EHR incentive program, which is broken down into two parts, meaningful use and clinical quality measures, the physician quality reporting system, and the value modifier. Once we go through each of these programs, we will look at how they are all related, looking at the different reporting options and payment adjustments, which will hopefully give you a deeper understanding of how these programs are largely dependent on each other. So let's get started with an introduction to quality reporting. Improving the quality of healthcare is a core function of the Centers for Medicare and Medicaid Services. For over a decade, the U.S. Department of Health and Human Services and CMS have launched quality initiatives to improve quality healthcare for all Americans through accountability and public disclosure. CMS supports healthcare providers in achieving better outcomes for beneficiaries and communities by driving care improvement through quality initiatives. What is quality reporting? Healthcare providers report quality measures to CMS about healthcare services provided to Medicare beneficiaries. Quality measures are tools that help CMS assess various aspects of care, such as health outcomes, patient perceptions, and organizational structure. The measures reported by healthcare professionals give the ability to provide high-quality healthcare and relate to the goal of effective, safe, efficient, and patient-centered, equitable, timely care. How does quality reporting affect you? By reporting quality measures, clinicians can assess the quality of care they provide to their patients. They can quantify how often they are meeting a particular quality metric, view their published quality metrics alongside that of their peers on the Physician Compare website, avoid PQRS negative payment adjustments, receive Medicare EHR incentive program incentive payments and avoid the program's payment adjustments, and avoid the automatic downward value modifier payment adjustment, and be eligible for an upward, neutral, or downward payment adjustment based on performance. So as you can see, lots of benefits both financially and in assessing the quality of care for your patients. We will talk about the financial incentives and downward adjustments associated with each program for the 2016 reporting year in depth later on. So what do EPs need to know in 2016? Well, MACRA condenses quality reporting into one program. 2016 is a year of transition from PQRS, VM, and MU, which all sunset, and then MIPS, the new merit-based incentive payment system, and APM's alternative payment models take over. To clarify, 2016 is the final year for PQRS, value modifier, and meaningful use, that they will all be individual programs with individual payment adjustments. These programs will sunset on December 31st, 2018, with new incentives through MIPS and APMs on January 1st, 2019. I know we've been talking about this and kept mentioning it, but it is happening right now. If we look at the MIPS performance score, we can see it's made up of 30% quality measures and 25% meaningful use. So when I say this is the final year for these programs, I mean this is the last year you report on these measures separately, but overall these programs will still collect similar information. Now, since 2018 is the final year for payment adjustment for these individual programs, it's important to note 2016 is the performance year to determine payment adjustment in 2018. And lastly, before we dive into each program, I wanted to include a resource MGMA actually sent out that shows how each program defines an EP. CMS defines an EP differently across the PQRS, the EHR Meaningful Use Program, and the Value-Based Payment Modifier. This chart will help you better understand which professionals may be considered EPs for each program, and thus could potentially face penalties for each program. EPs who do not successfully participate in the Medicare quality reporting programs in 2016 face up to an 11% penalty in 2018. We can see meaningful use has the smallest amount of providers that can be considered an EP compared to PQRS or VM. With PQRS, not only do we have physicians, but also a long list of practitioners and therapists, whereas VM has some practitioners but does not have any effect on any therapists. So first, we will start with the EHR incentive program, which contains two parts: meaningful use, which we're all familiar with, and clinical quality measures, or CQMs, which often get overlooked. So we will start by looking at meaningful use. First off, a reminder that failure to successfully test the meaningful use would result in a negative 3% payment adjustment in 2018. Now, we've already covered everything you need to know regarding meaningful use in previous webinars. Two topics that have been updated since we last talked are the hardship exception deadline and alternate exclusions for public health reporting. Let's first look at the hardship exception application. EPs who can participate in either the Medicare or Medicaid EHR incentive programs will be subject to payment adjustments unless they are meaningful users under one of the EHR incentive programs. EPs may apply for these hardship exceptions to avoid these payment adjustments. The application is now available on CMS's website with instructions, and this application will allow groups of healthcare providers to apply for a hardship exception together instead of each doctor applying individually. the deadline to submit a hardship application has been extended to July 1st, 2016, which you can see by the screenshot of the official CMS announcement sent out on March 25th. CMS does not require an EP to submit documentation for the hardship category selected, and CMS will not be reviewing documentation supporting the application on a case-by-case basis. CMS will review the application to record the category selected and use the identifying information to approve the hardship exception for each provider listed on the application. CMS specifically stated providers who experience an issue with their CEHRT related to the rule timing and any other provider for whom the timing of the rule caused a significant hardship should select subcategory 2.2D on the 2017 hardship exception application. CMS also published some FAQs related to public health reporting regarding what can count as a specialty registry, how providers should determine if there is a specialty registry available to them, and what alternate exclusions are available for public health reporting. All of these can be found on CMS's website in the FAQ section. And before we move on to CQMs, I wanted to share what NextGen released in response to these updated FAQs. They stated NextGen Healthcare always errs on the side of caution when it comes to advising clients on regulatory requirements. While these FAQs seem to signal the intent of CMS to allow providers to claim exclusions for both Measure 2 and Measure 3, NextGen Healthcare urges clients to carefully review the FAQs linked to this message. We recommend limiting the use of the exclusion to specialties for which there's no available registry with applicable clinical measures and/or situations where software upgrades or interfaces pose a challenge. So yes, there are alternate exclusions available, but take caution when claiming one. All right, on to clinical quality measures, which is the second part required to successfully meet meaningful use. CQM basics. Clinical quality measures, or CQMs, are tools that help measure and track the quality of healthcare services provided by eligible professionals, eligible hospitals, and critical access hospitals within our healthcare system. These measures use data associated with providers' ability to deliver high-quality care or relate to long-term goals for quality healthcare. CQMs measure many aspects of patient care. To participate in the Medicare and Medicaid EHR incentive programs and receive an incentive payment, providers are required to submit CQM data from certified EHR technology. So what do you report? Well, you must select and report 9 from a list of 64 approved CQMs, and the CQMs reported must cover at least 3 of the 6 available National Quality Strategy domains, which represent the Department of HHS NQS priorities for healthcare quality improvement. The domains are patient and family engagement, patient safety, care coordination, population/public health, efficient use of healthcare resources, and clinical process/effectiveness. Also, CMS has a recommended core set for adults and children. These recommended core sets focus on conditions that contribute to the morbidity and mortality of most Medicare and Medicaid beneficiaries. CMS encourages you to report from the recommended core set to the extent that those CQMs are applicable to your scope of practice and patient population. We're just going to look at the adult recommended core measures, which are controlling high blood pressure, use of high-risk medications in the elderly, tobacco use, screening, and cessation intervention, use of imaging studies for low back pain, screening for clinical depression and follow-up plan, documentation of current medications in the medical record, BMI screening and follow-up, receipt of specialist report, and lastly, functional status assessment for complex chronic conditions. The next question after what do you report is how do you report? EPs can report clinical quality measures several ways. Reporting options are listed on your screen, and options that only apply for the EHR incentive program are option 1, a test for the EHR registration and attestation system. Here you would report on 9 CQMs in at least 3 different domains. CQMs would be submitted on an aggregate basis reflective of all patients without regard to payer. And the reporting period is 90 days for your first year of participation or 1 full year for your second year and beyond. And the reporting, again, occurs through the EHR registration and attestation system. Option 2 is e-reporting of data. Here you would report 9 eCQMs in at least 3 different domains using the most recent version of the eCQMs. And the reporting period is, again, 90 days for your first year of participation and 1 full year for your second year and beyond. Reporting occurs through the PQRS portal using the QRDA format. Options that align with other quality programs. Option 3, satisfy requirements of the PQRS reporting options for individual EPs using CEHRT. Here you would submit and satisfactorily report PQRS eCQMs under the PQRS EHR reporting options, or satisfactorily report in the Qualified Clinical Data Registry using CEHRT. You would submit a full year, so January through December, of data electronically to receive credit for the Medicare EHR Incentive Program and PQRS. And reporting occurs through the PQRS portal. The same applies for option 4, which is report group CQMs through PQRS portal. And finally, EPs can also use option 5, report group CQMs through Pioneer ACO participation or Comprehensive Primary Care Initiative participation. Now we went over reporting options that aligned with other quality programs, otherwise known as aligned reporting. To reduce the burden on providers participating in multiple quality reporting programs, CMS has aligned several reporting requirements for those reporting electronically using an EHR. The criteria for satisfactory reporting under PQRS using an EHR are aligned with the Medicare EHR Incentive Program. Satisfactory reporting of PQRS EHR quality measures will allow EPs and PQRS group practices to qualify for the clinical quality measure component of meaningful use. If it's your first year meaningful use, your reporting period is 90 days for both PQRS and CQMs, only for aligned reporting. If it is beyond your first year meaningful use, reporting is 1 full year for both PQRS and meaningful use. And if you are not participating in aligned reporting, PQRS reporting is always a full year. So providers have this option of aligned reporting for PQRS and CQM measures. We've gone through the CQM requirement, so let's take a look at the Physician Quality Reporting System, or PQRS. The Physician Quality Reporting System is a voluntary quality reporting program that has a negative payment adjustment to promote the reporting of quality information by EPs and group practices. Those who do not satisfactorily report data on quality measures for covered Medicare physician fee schedule services furnished to Medicare Part B beneficiaries will be subject to a negative payment adjustment under PQRS. Medicare Part C, Medicare Advantage beneficiaries are not included. 2016 PQRS updates. There are a total of 281 measures in the PQRS measure set, 18 measures in the G-Pro web interface, and 23 cross-cutting measures. For those that are using the registry reporting option and are using measure groups, 3 new groups have been added: multiple chronic conditions, cardiovascular prevention, and diabetic retinopathy. New this year is the Qualified Clinical Data Registry reporting option. Previously only available to individuals, it's now available for group reporting as well. 2018 PQRS payment adjustment, based off 2016 reporting year, is the last adjustment that will be issued under PQRS. Starting in 2019, again, we see adjustments for quality reporting will be made under MIPS. Okay, so PQRS getting started. We will walk through each of these steps in depth. For an overall view, we have step 1, determine eligibility. Step 2, determine if you want to participate as an individual EP or as part of a group practice. Step 3, choose reporting method. Step 4, choose quality measures. Step 5, be aware of payment adjustment information. And step 6, review PQRS timeline. So step 1, determine eligibility. Find out whether you're eligible to participate in 2016 PQRS to avoid the 2018 negative payment adjustment. View CMS's PQRS list of eligible professionals to determine your eligibility. We mentioned this in the beginning of the presentation that each program has a different definition of an EP, and the PQRS program has a wide range of professionals that are eligible to participate, including practitioners and therapists, in addition to Medicare physicians. So step number 2 is determining if you will report as an individual or group practice, which is important and affects your payment adjustment. Individual EPs are identified on claims by their Individual National Provider Identifier, or NPI, and Tax Identification Number, or their TIN. A group practice under 2016 PQRS is defined as a single tax identification number with 2 or more individual EPs who have reassigned their billing rights to the TIN. Group practices can register to participate in PQRS via the Group Practice Reporting option, otherwise known as GPRO, to be analyzed at the group TIN level. Note that group practices participating via GPRO are referred to as PQRS group practices. Step 3, choose reporting method. So to participate in 2016 PQRS, individual EPs may choose to report information on individual PQRS quality measures or measures groups using the following mechanisms: Medicare Part B claims data reporting, qualified PQRS registry, direct EHR using CEHRT, CEHRT via data submission vendor, qualified clinical data registry. Individual EPs who meet the criteria for satisfactory submission of PQRS quality measures data via one of the reporting mechanisms listed above during the 2016 reporting period will avoid the 2018 negative PQRS payment adjustment. A group practice may also avoid the PQRS negative payment adjustment by meeting the criteria to satisfactory report specified by CMS. To participate this year in PQRS via GPRO, group practices must register to take part in PQRS GPRO by June 30th of this year. Registration must be completed online through the PQRS registration system. During registration, group practices must indicate their reporting method, as well as CAHPS for PQRS participation. They may choose to report information PQRS quality measures using the following mechanisms: qualified PQRS registry, GPRO web interface, direct EHR using CEHRT, CEHRT via data submission vendor, qualified clinical registry, and finally CAHPS for PQRS via CMS certified survey vendor. So you're required to select a reporting method, but what do you have to report? Each reporting method requires slightly different criteria, but overall the universal reporting criteria is very similar to CQMs. A provider must report on at least 9 individual measures covering at least 3 NQS domains for at least 50% of the EP's Medicare Part B patients. Measures with a 0 performance rate will not be counted. Now, when submitting CQMs via meaningful use attestation, a 0 numerator, 0 denominator is acceptable. When submitting PQRS, that's not the case. Data for both the numerator and denominator need to be submitted, and at best at high numerator values. Individual EPs or PQRS group practices are also required to report 1 cross-cutting measure if they have at least 1 Medicare patient with a face-to-face encounter. Measure applicability validation, or the MAV process, will be used if a provider reports less than 9 measures to determine if the EP could have reported 9 measures covering at least 3 domains. And the reporting period is again 1 year. Now we're going to go through each type of reporting option available by talking through these flowcharts CMS has provided in their latest quality reporting modules released this year. So for individual claims-based reporting, you will report quality data codes listed in the individual measure you've selected on the Medicare Part B claims, and make sure to report the QDC on each eligible claim. Failure to do so will be a missed opportunity which you cannot resubmit. An EP using this method will need to report on 9 measures over 3 domains, And if the EP sees at least one Medicare patient in a face-to-face encounter, they must report on at least one cross-cutting measure and report each measure for at least 50% of the Medicare Part B patients seen during the reporting period to which the measure applies. Again, measures with a 0% performance rate would not be counted. And if you're unable to report 9 measures, you can report 1 to 8, and you will be subject to the MAV, which will determine if you should have been able to report on 9 or not. Qualified registry reporting is a little bit more involved because an EP can report either individual measures or measures groups. And this is the only reporting method where measures groups can be used. Registries may now attest that quality measure results and all associated data are accurate via the web, so in lieu of a written attestation statement. And lastly, NextGen is a qualified registry. Specifically, NextGen states, HQM is a CMS qualified registry for 2016 for individual EPs and group practices electing GPRO registry reporting with CMS. Now, if you are reporting on individual measures, it's the exact same as claims reporting. We just went over. It's the 9 measures over 3 domains with 1 cross-cutting measure. However, if you're reporting on a measures group, an EP must report at least 1 measures group and report each measures group for at least 20 patients, a majority of which must be Medicare Part B patients. Measures groups containing a measure with a 0% performance would not be counted as well. Another individual reporting method is direct EHR product that is CEHRT, or an EHR data submission vendor that is CEHRT. For PQRS EHR reporting, CMS requires 2014 CEHRT, and NextGen EHR is 2014 CEHRT, and HQM is a data submission vendor for PQRS EHR reporting. It extracts quality measures data from CEHRT and submits it to CMS. As required by CMS, HQM uses the most recent eCQMs, that's the July 2014 version, for EHR reporting. With only 1 measure type, an EP must report 9 measures covering 3 domains. If the EP CEHRT or EHR data submission vendor does not contain patient data for at least 9 measures covering at least 3 domains, then the EP must report the measures for which there is Medicare patient data. So an EP must report on at least 1 measure for which there is Medicare patient data. Our last individual reporting method is a qualified clinical data registry. A QCDR is a CMS-approved entity that collects medical and/or clinical data for the purpose of patient and disease tracking to foster improvement in the quality of care provided to patients. A QCDR will complete the collection and submission of PQRS quality measures data on behalf of EPs. Providers can report individual PQRS measures and/or non-PQRS measures reportable via a QCDR. EPs must report on at least 9 measures covering 3 domains and report each measure for at least 50% of EPs' applicable patients seen during the reporting period to which the measure applies. Of the measures reported via a QCDR, the EP must report on at least 2 outcomes measures. Or if 2 outcome measures are not available, report on at least 1 outcome measure and at least one of the following. And that's resource use, patient experience of care, efficiency or appropriate use, or patient safety. Okay, now moving into group practice reporting. Group practices will be able to register for the PQRS GPRO between April 1st, 2016 and June 30th, 2016. So that time frame encompasses right now. Groups are able to go on right now and register. The size of the group will determine the group reporting options, and in this case, size is the total number of practitioners under 1 TIN in a group. So for this option, EPs in groups of 2 to 99 EPs, or 100 plus EPs where CAHPS for PQRS does not apply, they can report on 9 measures over 3 domains. The same applies to the cross-cutting measure and that 50% threshold. Now for CEHRT reporting, it's the exact same requirements for individual reporting, except this is for groups, again, of 2 to 99 EPs, and for those groups over 100 EPs that CAHPS for PQRS does not apply. Now this qualified clinical data registry reporting is the same for individual reporting as well. where an EP, again, is reporting on 9 measures over 3 domains with the 50% threshold. I want to point out again, of the measures reported via a QCDR, the group must report on at least 2 outcome measures. Now our last reporting option is the GPRO web interface. This option is for group practices with 25 or more EPs. Now some group practices might not have a sufficient number of beneficiaries to produce reliable data. So if you do not have a sufficient number of beneficiaries, they will be encouraged not to use GPRO as a reporting option and will be notified. The beneficiary sample size remains 248 beneficiaries for groups of all sizes. If there are less than 248 patients in the group practice, the group would report on 100% of assigned beneficiaries. And if a group does not have any Medicare patients for any of the GPRO measures in the web interface, another reporting option must be chosen. 18 measures have been finalized for GPRO, and if a practice picks GPRO, then they should be reporting on all 18 measures. So in summary, EPs must report on all measures included in the web interface and populate data fields for the first 248 consecutively ranked and assigned beneficiaries in the order in which they appear in the group sample for each module of preventative care measure. If the pool of eligible assigned beneficiaries is less than 248, then report on 100% of assigned beneficiaries. Okay, so at this point, an EP has determined their eligibility to participate in PQRS. They've decided to participate as either an individual or a group practice, and they've picked a reporting option. Now step 4 is choosing quality measures. Quality measures are indicators of the quality of care provided by physicians. Individual EPs and PQRS group practices should choose at least 9 individual measures across 3 domains, or 1 measures group as an option to report on measures to CMS. A measures group is defined as a subset of 6 or more PQRS measures that have a particular clinical condition or focus in common. All applicable measures within the group must be reported for all patients in the sample seen by the EP during the reporting period. Now, individual measures consist of 2 major components, denominators and numerators. Calculating the PQRS reporting rate, which is dividing the number or reported numerator, outcomes by denominator or eligible encounters, identifies the percentage of a defined patient population that was reported for the measure. So let's look at the measure selection process that CMS outlines for EPs. First, review the 2016 PQRS measure list available on the Measures Code section of the CMS PQRS website to determine which measures, associated domains, and reporting mechanisms may be of interest and applicable to the EP or group practice participating in PQRS. Some important things to consider are not all measures are available under each PQRS reporting mechanism. EPs or PQRS group practices should avoid individual measures that do not or may infrequently apply to the services they provide to Medicare patients. And the GPRO web interface reporting mechanisms has set measures, all of which must be reported. Step 2, consider the following factors when selecting measures for reporting. Clinical conditions usually treated, types of care typically involved, so think preventative, chronic, or acute, settings where care is usually delivered, in an office versus in an emergency department, and lastly, consider your quality improvement goals. And finally, after making a selection of potential measures, review the specification for the selected reporting mechanism for each measure under consideration. Select those measures that apply to services most frequently provided to Medicare patients by the EP or PQRS group practice. EPs or PQRS group practices should review each measure's denominator coding to determine which patients may be eligible for the selected measure. EPs can report individual measure or measures groups, while PQRS group practices can only report individual measures. Group practices must report using an EHR or via Registry in order to select their measures. The types of quality measures reported under PQRS change from year to year. The measures generally vary by specialty and focus on areas such as care coordination, patient safety, clinical process and effectiveness, and population or public health. They can also vary by reporting method. Individual EPs and PQRS group practices can also use the new PQRS web-based measure search tool to easily identify applicable PQRS measures. Users can search and filter important measure-related information, such as measure number, reporting mechanism, NQS domain, cross-cutting measure, and measure steward. The tool also allows users to view the individual claims and registry measure specifications for 2016. So that new tool is out there and it's available, and I think it's a great resource for everyone. I do want to point out there are inverse quality measures in PQRS. So most measures you want to have a high percentage to show a high performance rate. But there are inverse measures where the lower the numerator, the better the performance. Therefore, if you have a 0 for an inverse measure, it would be considered high performance, and 100% would indicate poor performance. The table below shows some of the inverse measures to look out for. So in addition to individual quality measures, inverse quality measures, and measures groups, we also have specialty measure sets. CMS is collaborating with specialty societies to ensure that the measures represented within the specialty measure sets accurately illustrate measures associated within a particular clinical area. These are suggested and not required. 17 specialties listed have a suggested measure set to aid an EP in these fields. And 5 new sets in orange were added for this year. That's dermatology, PT/OT, mental health, hospitalist, and urology. So just another attempt to try and make this process easier for physicians. Similar to how CMS has a recommended adult CQM list, they provided a recommended list of quality measures by specialties. Now, finally moving on to step 5, which is be aware of payment adjustment information. We're going to go into this in much more detail when we cover the value modifier payment adjustment information, which relies heavily on PQRS participation. But for now, we can see PQRS is a negative 2% adjustment for failure to participate. And again, we mentioned meaningful use is a negative 3% adjustment if an EP is not a meaningful user. And finally, step 6, review PQRS timeline. These were again provided by CMS and give a nice overview of PQRS milestones in the future. We can see we're mostly past everything for this year, and we're just going to go ahead and use this to look ahead to 2017 for next year and the different reporting deadlines. Now our last topic before we move into value modifier is CAHPS for PQRS. Notice this is the only reporting option that is offered to group practices that we did not go over. So a CMS certified survey vendor is a new reporting mechanism that began in 2014 and is available to group practices participating in the PQRS G-Pro option. This reporting mechanism is available to group practices of 2 or more EPs wishing to supplement their 2016 PQRS reporting with the Consumer Assessment of Healthcare Providers and Systems, or CAHPS, survey. CAHPS for group practices participating in PQRS G-Pro was developed to collect information about patient experience and care within that group practice. Although required for group practices of 100 or more EPs, this is an extra reporting option for groups with 2 to 99 EPs and for EHR and registry reporting. So basically, in 2015, CAHPS became mandatory for groups of 100 or more EPs, in addition to other reporting methods, and it's optional for groups with 2 to 99 EPs. So all group practices must select a CMS-approved CAHPS for PQRS survey vendor. Once a group practice has contracted with a vendor, they must communicate their selection to CMS by completing the 2016 CAHPS for PQRS survey vendor authorization form. You can find a list of approved vendors on CMS's website, but NextGen is not and does not plan to be a CMS-certified survey vendor. The CAHPS for PQRS survey measures 12 key domains of beneficiaries' experiences of care that we refer to as summary survey measures. The CMS-certified survey vendor will administer and collect 12 SSM modules on behalf of the group practice's patients. These results may be posted on the CMS Physician Compare website. The 12 summary survey modules for use with the PQRS program include those listed below. CAHPS Reporting. The CAHPS for PQRS survey is equal to 3 individual measures and 1 NQS domain. So for reporting CAHPS, only 6 measures over 2 domains will be required in addition to CAHPS. Beginning in 2016, the CAHPS for PQRS survey will have 4 options for group practices to satisfactorily report, and that's qualified registry, GPro web interface, direct EHR product or CEHRT, and direct EHR submission, and qualified clinical data registry. The requirements are the same for each that we went over, besides the slight modification that EPs only have to report on at least 6 additional measures outside of CAHPS for PQRS that cover only 2 domains. Now CAHPS and value modifier. Groups with 2 or more EPs may elect to have CAHPS for PQRS included in their VM quality composite calculation. The quality of care composite score determines 1/2 of the VM calculation. The CAHPS for PQRS survey falls into one of the 6 domains that contribute to the quality of care composite score. And 11 of the 12 SSMs contribute to the person and caregiver-centered experience and outcomes domain in the quality of care composite score. So as you can see, providers who report CAHPS may choose to have this be included in their VM calculation. Now PQRS and value modifier. For PQRS, an EP is only required to submit 9 measures covering 3 domains. If an EP chooses to submit more than 9 measures, special care should be taken to avoid reporting measures showing poor performance, thereby subjecting providers to negative payment adjustments under the value-based modifier. A potential downward adjustment under the VM quality tiering applies to all providers this year. So basically, if an EP has submits more than 9 PQRS measures, it would be in their best interest of the provider to submit only the 9 that have the best ratio. Keep in mind that when submitting CQMs via meaningful use, 0 numerators are acceptable and a 0 numerator, 0 denominator is acceptable. But when submitting PQRS, that's not the case. Data for both the numerator and denominator need to be submitted, and at best need to have a high numerator value. Remember, your participation in PQRS in 2016 will determine how the VM will be applied to reimbursement in 2018. So let's look at our last quality reporting program for today, and that's the value modifier. And I will turn it over to Kathy Thompson for this. Kathy?
Hello, good afternoon. Value modifier basics. The value modifier assesses the quality of care and the cost of care furnished to Medicare fee-for-service beneficiaries during a performance period. The VM is an adjustment made on a per-claim basis to Medicare payments for items and services furnished under the Medicare physician fee schedule. The value modifier is applied at the taxpayer identification number, which is also known as the TIN, level. Additional reporting outside of PQRS is not required under the VM. CMS began phase-in of the value modifier in 2015 based on 2013 reporting for groups of 100 or more EPs. Phase-in will be completed in 2017 when the value modifier will be applied to solo practitioners and groups of 2 or more eligible providers. Implementation of the value modifier is based in part on participation in Physician Quality Reporting System, otherwise known as PQRS. The value-based payment modifier applies to all physicians. The value modifier uses PQRS quality data and Medicare cost data to determine a provider's overall score. It rewards high-quality performing providers with increased payments and reduces payments to low-performing providers. This will affect approximately 900,000 physicians. Phased. The phased-in approach to payment adjustments. In calendar year 2018, Medicare will apply the value modifier to all physicians and non-physicians who are solo practitioners or in groups of 2 or more eligible providers. This policy expands the application of the value modifier to include all non-physician EPs. In calendar year 2017, Medicare will apply the value modifier to physician payments under the Medicare physician fee schedule for physician solo practitioners and physicians in groups of 2 or more EPs.
In calendar year 2016, Medicare will apply the value modifier to payments under the Medicare PFS physician fee schedule for physicians in groups of 10 or more EPs. Beginning in calendar year 2015, Medicare applies the value modifier to payment under the Medicare physician fee schedule for physicians in groups of 100 or more EPs. Please note, value modifier is applied 2 years after the actual performance year. "2018 value modifier, what you need to know." 2016 is the performance year for application of the 2018 value modifier, and the 2018 is the final year for value modifier. It applies to all physicians and also to physician assistants, nurse practitioners, clinical nurse specialists, certified registered nurse anesthetists. In groups of 2 or more EPs, and those who are solo practitioners as identified in their TIN, quality tiering is mandatory. TINs consisting of non-physician EPs only will be held harmless from downward payment adjustments if they successfully report PQRS measures. All other TINs will be subject to upward, neutral, and downward payment adjustments. How the VM works. PQRS, reported quality information, along with CMS calculated outcomes and cost measures are analyzed. Each group practice receives 2 composite scores, a quality and cost composite as shown in the graph to the right. CMS classifies each score into high, average, or low based on standard deviation above, below, or at a national mean score. This identifies statistically significant outliers. CMS assigns groups to their respective quality and cost tiers to determine a positive, neutral, or negative payment adjustment to their payment based on performance. This is known as quality tiering analysis. Quality measures used to calculate 2018 VM under quality tiering. Quality measures. Groups with 2 or more EPs, measures reported through the PQRS Group Practice Reporting option, GPRO, selected by the group or individual PQRS measures reported by at least 50% of the EPs in the group, 50% threshold option. Physician solo practitioners, individual PQRS measures reported by the solo practitioner. 3 claims-based outcome measures, all-cause hospital readmissions, composite of preventable hospitalizations for acute conditions, and composite of preventable hospitalizations for chronic conditions, and CAHPS for PQRS survey measures, applicable only for groups that elected to use their 2016 CAHPS results in the calculation of their 2018 value modifier. Quality tiering. The VM is calculated for a group using a quality composite score and a cost composite score. The quality composite scores are derived from 6 quality domain scores. Each domain score is based on performance scores for PQRS measures reported using its associated domain. Quality tiering will determine if group performance is statistically better, the same, or worse than the national mean, based on the standard deviation calculations. Quality tiering. Using quality and cost composite scores, a group will be assigned one of 9 possible ratings as indicated in the table shown in the slide. Table 1, quality tiering approach for 2018 value modifier for physicians, PAs, nurse practitioners, and CRNAs, and groups with 10 or more eligible providers. Table 1, this is the same as last year. An automatic negative 4% value modifier downward adjustment will be applied for not meeting the reporting criteria to avoid 2018 PQRS payment adjustment. The maximum adjustment is up to 4x. X represents the upward value modifier payment adjustment factor, and the maximum downward adjustment is negative 4%. All value modifier adjustments have to be budget neutral. That is why CMS has not specifically stated the upward payment percentages. How much money they have available from collecting negative payment adjustments to give out includes downward and automatic for failure to report PQRS. This means if you fall into the category and do not report PQRS and fall into a high-cost, low-quality range, your downward adjustment will be -8%. Table 2. This is different than last year since now both upward and downward adjustments apply. An automatic -2% value modifier downward adjustment will be applied for not meeting the reporting criteria to avoid the 2018 PQRS payment adjustment. The maximum upward adjustment is up to 2% and the maximum downward adjustment is -2%. And finally, Table 3. This is a new year for this year. This is new for this year. An automatic -2% value modifier downward adjustment will be applied for not meeting the reporting criteria to avoid the 2018 PQRS payment adjustment. The maximum upward adjustment is up to 2x, and this specific group is held harmless from any downward adjustments for poor performance. What this means is PAs, NPs, CNs, and CRNs in groups consisting of non-physician EPs only, and those who are solo practitioners receive only upward and neutral value modifiers adjustment, no downward adjustments. While physicians, PAs, nurse practitioners, CNs, and CRNAs in groups of physicians with 2 or more EPs and physician solo practitioners can receive upward, neutral, or downward value modifier adjustments. Value modifier and other initiatives. CMS provides specific policies through rulemaking regarding application of the value modifier to TINs participating in Medicare Shared Savings Programs, ACOs, Pioneer ACOs, the CPC initiative, and other similar initiatives. I am now going to hand it back off to Lindsay Lanning to discuss how it all relates.
Great, thanks, Kathy. So let's take a minute and look at how all of these programs relate and depend on each other. Now, if we look at this chart, it shows the payment adjustments for 2018 for each program side by side and is broken down by provider type. It shows incentives in 2016 and payment adjustments assessed in 2018 based on participation in these programs. Green columns are potential incentives and red columns are potential negative payment adjustments. This chart specifically shows physicians. Instead of walking through this in detail, I just want to point out that the total Medicare payment adjustment at risk for non-participation in PQRS and meaningful use is -7% for physicians in groups of 2 to 9 EPs and -9% for physicians in groups of 10 or more EPs. CMS finalized the policy to include PAs, NPs, clinical nurse specialists, and CRNAs for assessment of VN in 2018 based on this year's performance. This chart shows how these practitioners will fare under these programs during 2016 performance. So again, I'll just jump to the end and point out the total Medicare payment adjustment for non-participation of these specified practitioners in PQRS and meaningful use in 2016 could be a total downward payment adjustment to Medicare reimbursement anywhere from 2 to 6% in 2018. And finally, this chart covers the reimbursement for non-physician practitioners who are not PAs, NPs, CNSs, or CRNAs. As for PQRS, all EPs listed are subject to payment adjustment for PQRS in 2018 if they do not successfully report this year. Since VM and MU don't apply in large part, the total Medicare payment adjustment at risk for non-participation in PQRS for non-physician practitioners is -2%. Now, the following slides I included for your reference since we're not going to have time to go over the depth, but they do give a good overview of how the programs align. So this one is, how does 2016 PQRS participation affect VM in 2018? Then we have how to report once for 2015 Medicare quality reporting programs. This one is specifically for individual EPs. And this is the exact same flow chart just for group practices. And finally, I know after this webinar you may be feeling a bit overwhelmed. It was a lot of information, but CMS can help. They have help desks for each program that have information specialists waiting to answer your questions. As always, we at Attentive can also help. We can help assess your current readiness, provide recommendations, and implement new processes or procedures. And if you're not sure what your next steps are, visit our website or reach out to us in any way. And finally, we're going to go ahead and open up to questions. So thank you for everyone for sticking it out to the end here. And Chelsea, I will go ahead and turn it over to you now.
Great. Thank you, Lindsay. That was so much information, and many thanks to Kathy as well. At the moment, it looks like we only have 3 questions. So if you have any questions, as a reminder, you can type them in the webinar control panel, and we should be able to get to them pretty quickly. Otherwise, if you think of them later, information is up on the screen. Please feel free to reach out to us there as well. Okay, first question. If you fail to report all 9 measures for PQRS, will you automatically get a penalty?
I can grab that one if you want, Kathy. Yeah, so basically, we have now PQRS ended incentive payment. So if you fail to report PQRS and you are not participating, you will have an automatic -2 downward adjustment.
Thanks, Lindsay. As a reminder, we are going to post a recording of the webinar as well as a PDF download of the slides to our website probably Friday, and I'll be sending out an email to everybody as well with a link to that. And follow us on social media as well, as we always post when we put anything up on Facebook, LinkedIn, Twitter. And if you don't receive an email from me that has a link to the copy of the slides and recordings, feel free to shoot any of the people you see up here an email or me an email. Sometimes they happen to go into spam boxes. So just a thought, if you don't see them, you should. Everybody who registers automatically will get sent an email about it. Next question, and Kathy, maybe you can answer this one. Do CQMs count towards PQRS registry reporting?
No, they are separate reporting. So if you report your CQMs with your meaningful use attestation, you should still be reporting your PQRS registry measures separately. You can decide not to report your CQMs via your meaningful use attestation, in which case you can report them with your PQRS measures.
Thank you, Kathy. And it looks like this is our last question at the moment, so feel free to type them if you have any. Otherwise, we'll end on this, and we're actually going to end on time, so that's thrilling. So final question. If CQMs are submitted via meaningful use attestation, do they also have to be included with the PQRS reporting?
No, they do not. They're a separate reporting.
Okay, so you got to report them both. Well, everyone, thank you so much for joining us today. I hope that this helped to answer some of your questions, and hope that you got something out of it. And as always, don't hesitate to reach out to us if you have any questions on anything at all. And Kathy, Lindsay, thank you so much for all the effort that you put into making this presentation today.
Thank you, everyone.
Thank you.